Good evening, everybody. So it's our 48th meeting today. It's in English. We have wonderful guests from Canada. But before I will introduce them, actually they will introduce themselves. I would like to tell you we are on free channels on the YouTube, Facebook, and the Pharmacy College website. Also, we are inviting you to the closed group Pharmacy College, where you can just exchange all your thoughts and ideas. So today actually it's 48th webinar with us. So we are hoping that you are enjoying this time with us, and you always wait for this great zest of knowledge that we are just providing through our webinars. Thank you, first of all, to Dr. Regis Vaillancourt, who helped us to organize these meetings with our friends from Canada. Today, we are going to talk about clinical pharmacy, and we are going to have two excellent lectures. Today with us is Kendra and Rose. Hello, Kendra. If you could just please kindly introduce yourself.
Just introduce myself.
Yes,
my name is Kendra. I'm a pharmacist working in Vancouver, British Columbia, on the west coast of Canada. And I'm in my second last rotation of my PharmD for Pharmacist program at the University of Toronto. So I've been at CHIO for the past 5 weeks, initially in oncology, which is what my presentation will be on, and currently working in critical care.
Excellent. Thank you very much. And our second speaker is Rosa.
Hi, my name is Rosa. I'm a pharmacy student at the University of Toronto in Central Canada. I'm in the Doctor of Pharmacy program, and this is my second last rotation as well at the Children's Hospital of Eastern Ontario, and I'll be presenting on chronic pain and mental health today.
Fabulous. So we're going to have very interesting topics and highly advanced speeches, basically. So please kindly ask the questions. Our system will work this way, that we are going to present. During the presentation, we can ask some questions, but also we'll give you like 5 minutes after finish the first and the second session to ask some additional questions if there are any. So thank you very much, Kendra. We could just share the screen and let's go.
Okay. You can see that okay?
Something is happening. That's good. Excellent.
Okay. Perfect. Okay. So my topic is going to be on chemotherapy-induced nausea and vomiting. So as I said, I've been working in oncology. So this is where this topic came from. So chemo-induced nausea and vomiting, a preventable outcome. So my objectives are listed here. I think they were sent out with the presentation invite. So I won't go through them for the sake of time, but the outline of the presentation, we're going to talk about some definitions around nausea and vomiting and chemotherapy-induced nausea and vomiting. I'm going to use a patient case throughout the presentation to apply some of the information. We're going to review nausea and vomiting pathophysiology so we understand why we use particular medications, as well as guidelines for prevention of chemo-induced nausea and vomiting, and the specific medications, and then at the end we'll summarize everything. So why is this an important topic? Chemo-induced nausea and vomiting affects 70 to 80% of patients, and it's the most documented distressing side effect of childhood cancer treatment. There's definitely negative outcomes from having chemo-induced nausea and vomiting, so it can influence compliance with the chemotherapy treatment. It can cause anorexia, malnutrition, dehydration, and poor quality of life for the patient. More seriously, there is the risk of having a torn esophagus, broken bones, reopening surgical wounds, and it can impact the length of hospital stay. And poorly managed chemo-induced nausea and vomiting can lead to anticipatory and refractory nausea, which is much more challenging to treat, and we have fewer medications for that. So prevention is ideal. So first off, let's define nausea and vomiting. I'm sure we've all experienced this at some point in our life, but nausea is the unpleasant feeling in the back of your throat or the stomach that may come and go in waves, may occur before vomiting, but doesn't need to include vomiting. Whereas vomiting is the actual throwing up of the contents of the stomach, involves contraction of the gut, the abdominal wall musculature, and it's a reflex response. And then the third definition is retching, physical movement of the stomach and esophagus without actually vomiting, and that can also be called dry heaves. So with respect to chemotherapy-induced nausea and vomiting, there are specific definitions. So the presentation is going to focus mostly on acute and delayed chemo-induced nausea and vomiting. So acute most commonly begins within 1 to 2 hours after the patient receives their chemotherapy, peaks a few hours later, and that resolves within 24 hours. After that, it's considered to be delayed onset. So that can occur after 24 hours and within 5 to 7 days after the chemotherapy. Some chemotherapy agents have a biphasic pattern, and my next slide will show a diagram of that, so we can go through that then. And then breakthrough, that can happen at any time. So that's when prophylactic antiemetics are not effective and rescue medications are needed. Anticipatory and refractory is really what we're trying to prevent by managing that acute and delayed response. So anticipatory occurs before chemotherapy, and it's usually associated with poorly controlled nausea and vomiting from previous cycles. That can occur in about up to 25% of people. Refractory is when the antiemetics are no longer working, and as I said, much more difficult to treat. So this diagram, because I'm a bit more of a visual learner, I wanted to put this in here. So along the x-axis, you can see the different phases, so the different definitions of what we just talked about. On day -1, so before chemo was given, you have that anticipatory phase. Then for the first day, you have acute nausea and vomiting. From days 1 to 5 in this diagram is the delayed nausea and vomiting. And then above that, you can see some neurotransmitters. So we're going to get into this when I talk about the pathophysiology. So I won't talk about it too much here, but serotonin and substance P will be the ones we talk about. And then that biphasic chemotherapy agent that I talked about, the example here is cisplatin. So that's the blue line. So you see cisplatin peaks in the acute phase. So you get one wave of nausea, and then you get a second wave in the delayed phase of the curve. Versus cyclophosphamide carboplatin, you get more of just one peak, but it also has a delayed response for nausea and vomiting too. So the overall goals of treatment or prevention of acute chemo-induced nausea and vomiting is optimal control, which is defined as no vomiting, no retching, no nausea, no use of medications other than what's given for prevention, and no nausea-related changes to the child's usual appetite and diet. The goal is to achieve this on each day that chemo was given and for 24 hours after the last dose of chemo in that block of treatment. I put this in here for completeness sake because I think it's important to know what scales are out there and how you would assess a patient. It's obviously more difficult to assess symptoms in a patient, like a pediatric patient, but this is one scale that's standardized for children over the age of 4. So this could be used on a ward, it could be used in the community, and ideally it would be done twice a day during each chemo cycle to help track how the nausea symptoms are improving or gone, or the response to therapy.
Kendra, I'll
Yes.
just ask you a question. If you could just go back
Sure.
one
Yep.
slide. Could you just explain about this form, about this exact assessment? Yeah, assessment of It's like because in Poland pharmacists are not on the ward, and so
Right.
where is the point that the pharmacist is actually performing this assessment? Where is it? Where is it? How do you do that?
Okay, so this could be done in the community, so in a pharmacy, I suppose, or it could be done in hospital. It could be done in a doctor's office, really anywhere. It could be done at home as well if the patient happens to be at home. So the idea behind this is the caregiver, so the parent, usually, depending on the age of the child, is taught how to perform this scale. And the questions are asked of the child that's receiving the chemotherapy. So I didn't put it in here, but generally they'll ask them to rate their nausea. So they use the language that makes sense to the child. So that's the first step, is to determine what does the child describe as being nausea. So they use that term each time, and then they ask the child to basically decide based on these 4 pictures here how they're feeling in that moment. So ideally it would be done before chemotherapy to get a baseline, and then each day that chemotherapy is given, the recommendation is twice a day during chemo, and And as I said, it should be from the child. So the child should be saying, today or in this moment, I feel more like number 4 or more like number 2 or something like that. And then you would document that.
Okay, and this is a regular assessment, or just once at the beginning, or how often do you do that?
Twice a day is the recommendation. So you would do it every day that chemotherapy is given, twice a day. Okay,
and is it just a normal part of practice that you have to perform this assessment for every kid, every child that is undergoing the chemotherapy?
I wouldn't say that it's necessarily a normal part of practice, but certainly it would be a way to assess and track how the patient is doing. There's different scales that are out there. This is the one that I found that was standardized for children, which is, it tends to be more useful when it's been standardized.
Okay, and because you just told me that not every child is undergoing this assessment, so what kind of kids or what kind of patients, young patients, they are just applied to this assessment?
Well, this can be used. So there's, I only put the one diagram here, but it looks very similar for older children. So they still have to rank themselves from the faces. So it's really just the terminology that gets used for younger patients versus older patients. So it's really just making sure you, because there's language differences, there's maybe cultural differences in how people describe nausea. So there might be a term that's used, or say like upset stomach versus upset tummy, or nausea versus feeling sick or something like that. So you need to make sure that you have like the patient specific or family term, which I think is in this diagram here. Yeah, it says to describe how bad your child's nausea or family term is. So that's important. And then that can obviously change for a younger patient versus an older patient.
Okay, and when you say twice a day, so is it normally in the morning after the kid is waking up, or it's just before going to bed?
Yeah, I think at any time. There's no specified time that's best. It might depend on when their chemotherapy is happening. So say their chemo is happening at noon, if it's an IV preparation. So maybe you would do it before that happens, and then after, say 4 to 6 hours afterwards, but there's no specified time. On the chart, you would record what time you do it at.
Okay, and I understand that an outcome of this assessment is that you'll be able to provide special medicines, basically, that and the right dose and the right timing. Is that correct?
Yeah, so it's just a way to track. So as I get further into the presentation, I'll talk about what we use for prevention. So if you're going to use medications, you should be able to track to see if that's effective or not. So this would be a bit more of a, I'm trying to think of the word, but just a way to document, I guess, how the patient is doing and if they're responding to the preventative therapy you're using.
I'm maybe asking weird questions for you, but unfortunately, the clinical practice in Poland is just at the beginning of its progression. So I thought I would just go deeply into this problem and this assessment questionnaire, to explain to the Polish pharmacists as well how it's working in Canada.
Yeah, no problem. Did that answer your questions for now?
Thank you very much, Kendra.
Okay. So that's assessment. And then I'm going to talk about a patient that I met in my first week of my rotation, just to use as an example, because I think that's useful. So I'm going to use her initials, AR. So she's a 6-year-old female, previously healthy. She presented to the emergency room with recurrent fever. Back in January, she had a fever and she had upper respiratory tract symptoms, so cough and congestion. She was treated with amoxicillin and started on some inhalers or puffers. And at the time, the fever resolved, but it came back, and the patient was quite fatigued and had poor appetite. The initial workup for infection was negative in the community, so COVID and strep throat. And then when she came into CHIO, to the hospital, her blood work showed a pancytopenia, as well as peripheral blast cells. So she was actually diagnosed with an acute myeloid leukemia, or AML, and she was also being treated for febrile neutropenia. So her chemotherapy treatment, so she was started on cycle 1, we call it cycle 1 of induction phase of the AML protocol. So that included cytarabine, daunorubicin, and etoposide, and the dexrazoxane is there for cardioprotection for the daunorubicin. So I've put a table here just to give you an idea of what her chemotherapy regimen looked like. It was a 10-day course for her first cycle, and we'll come back to this after I talk about some of the mechanisms and the medications. So we're going to review this really briefly because it turns out that the nausea mechanism is actually quite complicated. And for the sake of time, I'm going to try to simplify it as much as I can. So there are 5 sites within the body that you need to think about when you think about nausea and the impulse to have vomiting. So there's a peripheral pathway, which includes the gastrointestinal tract, and then the rest occurs mostly in your brain. So there's the central nervous system, which includes your cortex, the thalamus, hypothalamus, and meninges, and that responds to sensations. So things like pain, anxiety, things that might trigger nausea. Your vestibular system is more so related to your inner ear. So you think about motion sickness with the vestibular system. So neither of those are largely implicated in chemotherapy-induced nausea and vomiting. So we're not going to focus too much on them. But the 3 that are important are the gastrointestinal tract, the chemoreceptor trigger zone, or the CTZ, and the vomiting center. So to try to make some sense of it, I made my own diagram, which looks a little bit sketchy, but I think it makes a little bit more sense to me. So I'm going to break it down by peripheral pathways versus central pathways. So we'll start with a peripheral pathway on the left-hand side of the screen, hopefully for you guys as well. So in the periphery, in the GI tract, what happens with chemo is that when chemo is introduced into the body, in the periphery, it causes the enterochromaffin cells in the gastrointestinal tract to release serotonin. So that serotonin then binds to its serotonin receptors, and that moves and sends an impulse to the chemoreceptor trigger zone, which has serotonin receptors on it, as well as in the vomiting center, which sort of coordinates the vomiting and nausea response to that. So that's the peripheral pathway. And then in the central nervous system, there is another side that uses substance P. So when the patient is given chemotherapy, substance P gets released, and that binds to the neurokinin receptor, and then you get a stimulation of vomiting and nausea. So serotonin and substance P are sort of the 2 main things to remember from this slide, but note that there are multiple receptors. So all of these can be worked on and can stimulate nausea and vomiting, but for the purposes of chemotherapy, we're just going to talk about substance P and serotonin. So we'll talk about some of the guidelines. There are several guidelines for chemo-induced nausea and vomiting, less so in the pediatric population, but the ones that we'll focus on today are from the POGO group. So that's the Pediatric Oncology Group of Ontario, and those guidelines have been adopted by the COG group, which is the Children's Oncology Group. So POGO last updated their acute chemotherapy-induced nausea and vomiting guidelines in 2017, and the COG group, their most recent update was in 2020. So when we come to assessment of your patient, so you have a patient in front of you that's going to be starting chemotherapy, you have patient-specific factors and you have regimen-specific factors that can increase the risk of that patient experiencing nausea and vomiting from their chemotherapy. So on this slide here, you'll see patient-specific factors. So I'm not going to read through them, but I have starred the ones that are relevant to the patient case that we've already talked about. So our patient is female, she's 6 years old, she was constipated when she was down in the emergency room, and she's dehydrated. So she does have risk factors just within herself to experience nausea and vomiting from chemotherapy. And then comes the actual treatment, so the chemotherapy itself. So each chemotherapy agent has its own potential to cause nausea and vomiting, and that's considered or called the imitogenic potential of that medication. So this is ranked by minimal, low, moderate, and high risk. The minimal risk patients, less than 10% of those patients will experience nausea and vomiting. Low risk chemotherapy is 10 to 30%, moderate is 30 to 90%, and high is quite high, and more than 90% of patients that are given that particular drug will experience nausea and vomiting if we don't give them preventative medication. So that's with a single agent. Most of what I saw on oncology was patients receiving multiple agents over multiple days. So what you would do in those situations is you would look at each individual drug, and then you would go with the highest emetogenic potential agent. And that's how you would base your preventative therapy strategy. So for an example, just so that makes sense to everybody. So the patient case, so she was on cytarabine, daunorubicin, and etoposide. This table is from the guidelines. So at the top there, you've got high level risk, moderate risk, low risk, and then minimal at the bottom. So I've circled in red where her chemotherapy falls. And you'll see the daunorubicin is under moderate level risk. So we would consider her chemotherapy to be a moderate risk. So she's at 30 to 90% potentially to experience chemo-induced nausea and vomiting without any medication to prevent it. And then the stars on the table are just to make a note that some agents are dose specific. So cytarabine, for example, depending on the dose, can be either a moderate risk or a high risk. So that's important. You don't just see cytarabine and go with it because you might need to look at the dose.
Kendra, and when we are talking about guidelines, can you just explain also what is the role of guidelines? Like, I know the question is, again, very weird, but guidelines are extremely important, and it's because of the safety, but also, like, if you could just explain why you need guidelines in treatment.
Yeah, so guidelines basically look at the evidence that we have available to us, which in the pediatric population is smaller than the adult population. So sometimes we have to extrapolate from what we know from adults. But guidelines basically look at the evidence we have for efficacy and safety for a particular treatment. And then they lay out, usually very clearly, with specific examples of how you would apply that evidence to a patient. So I'm going to go through a bit of the guidelines. So hopefully this will make a little bit more sense. But for example, the guidelines create this ranking system for how you would determine what a chemotherapy agent will do. So there's minimal risk, low risk, moderate risk, high risk of potential to cause nausea and vomiting. That all comes from guidelines. So they've looked at the evidence, they've looked at clinical trial data, case reports, that sort of thing, and compiled all that information for the practitioner. So we don't have to go figure that out. They've laid it all out for us where the information is available. So this is also in the guidelines. So once you've figured out what risk your patient is at, in the guidelines, there are nice flow charts for each potential scenario. So the high emetogenic risk patients, this is the flow chart that they would follow. So it is nice. It makes things a lot simpler for you in practice. You're not having to figure this out for yourself. It's quite clear, and the safety and efficacy has been reviewed by a panel generally of people, and you can be quite confident in your recommendations. So I hope that answers a little bit more about the guidelines question.
And Kendra, and when you have a doctor and you have a pharmacist, so like, because in Poland many doctors are like following guidelines. Pharmacists, unfortunately, they don't have this role yet. So when you are a pharmacist, do you show these guidelines to the doctor? How do you apply these guidelines to your cooperation with the doctor?
Sure. So in my practice, the doctors have the same guidelines that the pharmacists do. So we have access to the same information. So if the doctor, for whatever reason, is not aware of this particular guideline, for example, and you want to make a recommendation about the type of medication or the dose or whatever you want to use in the patient in front of you, you could certainly go through the guidelines with the physician. But in this particular case, in oncology, the doctors are very aware of the guidelines that are out there. I think I do talk about a bit of the pharmacist role at the end of this presentation, but I do think one of the pharmacist roles is to remind the doctor of the guidelines and make sure that we're actually following the guidelines, because that's why they're there, right? They're the best evidence that we have. And you do have situations where you have to go outside of guidelines because of patient-specific factors, or the patient hasn't tolerated everything from the guidelines. So you do have to go outside of the guidelines sometimes, but it's certainly the best evidence that we have. So we should be starting with the guidelines. So yeah, it's definitely working with the doctors and then looking at the patient in front of you, because not every patient fits all the criteria that the guidelines lay out. So in this particular example, so as I said, this is the high risk chemotherapy agents. The first thing you need to do, and we are going to talk a bit more about these medications, but the first thing you need to do is decide if the patient can use steroids. So steroids, because I work in the adult population more so, I see steroids quite a bit being used, but in the pediatric population, there's actually a fair number of contraindications, and there's a lot of kids that aren't able to use steroids. And the contraindications are CNS tumors, so brain masses. And the reason behind that is that it's thought that dexamethasone will reduce the efficacy of chemotherapy that's targeting the CNS, because it decreases penetration of the chemotherapy. And dexamethasone is also contraindicated in leukemias. In AML, so that's what the patient has in this patient case. The risk is that the data shows that there's increased risk of infection, sepsis, and death when steroids are used in AML. And then in ALL, which is acute lymphoid leukemia, dexamethasone is actually used as part of the treatment protocol. So you don't want to increase the exposure that the patient has to dexamethasone. So that's the first step, basically. So you decide what risk the patient is at, can they use steroids or not, and then you follow the flow chart. In this case, it goes by age, and then it talks about a couple of the other medications, which we'll discuss just in a few more slides here. So there's one for moderate risk, which is what our patient case is. So it's laid out very similarly. The low and the minimal risk, because the risk is obviously lower in a low emetogenic risk chemotherapy, they only recommend using one agent as a regularly scheduled drug. And then the minimal risk, they don't actually recommend anything routinely, but certainly if your patient has had nausea and vomiting or has more patient-specific risks, then you might want to consider adding something in. The guidelines also give you the approved dosing for the medications. I'm not going to discuss this here because we don't have much time to do that, but they are available in the guidelines, so we don't need to worry about it too much. And then we're briefly going to talk about some of the medications. I just wanted to remind everybody about the neurotransmitters that we talked about at the beginning of the presentation. So the serotonin ones from the gastrointestinal tract, the substance P that works on the neurokinin receptors, and that's more of a central process. So those are some of the drug targets, as well as the steroids. So we did talk about steroids briefly already. So dexamethasone, prednisone, and methylprednisolone are the ones that you would most commonly see. The use of dexamethasone in combination with a serotonin antagonist is actually better than using either drug alone. So that's why it's in the guidelines. If you're able to use steroids in that particular patient, it's better to use it in combination with other therapy as well. The mechanism of action is not actually known for steroids in the setting of nausea and vomiting, but it certainly works well when it can be used. And it's best used for acute and delayed, which is, again, the focus of this presentation. So if you're able to use steroids, then use them. And it has the typical side effects of steroids, so hyperglycemia, insomnia, increased appetite, psychosis, hypertension, and masking the signs of infection. So these are the things you would want to be monitoring for as the pharmacist, as the team on the floor, as the caregivers at home, wherever the case may be. These are the side effects that would be important to monitor. As I mentioned, the contraindications in CNS tumors and leukemias. And the other thing I've just mentioned on the slide is that dexamethasone is a nicer drug to use, A, because of its half-life, so it has a long half-life, and B, because it has less risk of sodium retention, so fewer of the cardiovascular or blood pressure side effects, unlike prednisone or methylpred. The second class is the serotonin antagonist. So again, this is working on the gastrointestinal peripheral pathway, and it mostly works in acute chemo-induced nausea and vomiting. There are first generation and second generation serotonin antagonists. So the first gen ones are ondansetron and grunetsitron. Second generation is palonosetron. The advantage of the palonosetron is that it has a long half-life, which I put on the slide on the side there. So the half-life of the second generation serotonin antagonist is much longer. It's about 40 hours versus 3 to 6 hours. So the palonosetron actually has better data for delayed chemo-induced nausea and vomiting. It is more expensive, though. It's not currently on formulary at CHIO, so cost could be an issue because the families would have to bring that into the hospital or buy it in the community for at home. But it could have an advantage in delayed chemo-induced nausea and vomiting. The mechanism of action, as we discussed already, so it blocks peripheral and central serotonin receptors. Pretty well tolerated, headache, constipation, diarrhea, lightheadedness, dry mouth. QTC prolongation is something that's a problem with all of the serotonin antagonists. In a pediatric patient, the risk is arguably a little bit lower because the doses don't tend to be as high, although you can certainly get quite high doses if the kid is a larger child. But they don't tend to have as many cardiovascular risk factors versus an adult patient on a serotonin antagonist. But certainly if they have cardiovascular risk factors or their baseline QTC is prolonged already, or they're on other medications that will prolong the QT, you would want to monitor with ECGs. And then the last group that we're going to talk about is the neurokinin inhibitors. So this is working from the central pathway, and it's mostly indicated for delayed chemo-induced nausea and vomiting. So substance P seems to be more of an issue for that delayed response to chemotherapy. So these medications include aprepitant, fosaprepitant, which is a prodrug of aprepitant, and it's an IV formulation. And then there's a combination of a neurokinin receptor inhibitor and the serotonin antagonist, palonosetron, which is that long-acting serotonin antagonist. Mechanism of action, as we discussed, prevents substance P from binding to the neurokinin receptors, and those are found centrally in the vomiting center. And there's more evidence to suggest that they're also peripheral receptors in the gastrointestinal tract. So they are indicated for acute and delayed, but their best benefit is in delayed. They also can have some side effects, but they're pretty well tolerated: fatigue, diarrhea, constipation, hiccups, headache, neutropenia, which could be hard to differentiate from neutropenia just from the chemotherapy alone, but would be monitored with blood work. From a safety standpoint, you'll see on the flow charts that not everybody is able to have aprepitant, and that's because of drug interactions. So aprepitant is a CYP3A4 inhibitor and a weak 2C9 inducer. So you do have to be careful with drug interactions. One in particular, if you are combining it with steroids, is that it'll increase dexamethasone levels. So you actually decrease the dexamethasone dose by 50%. And the old chemo-induced nausea and vomiting guidelines didn't actually recommend aprepitant for kids under the age of 12 because it hadn't been studied, so they weren't sure about the safety. But there were 2 RCTs done in 2015 looking at about 400 kids, and they didn't find any increased side effects in the younger population, but they found better benefit with the delayed chemo-induced nausea and vomiting. So the 2017 guidelines have approved it for kids over the age of 6 months because now they have some more safety data. The rest of these medication classes I'm not going to talk about for the sake of time, but they're commonly used in nausea and vomiting, but they aren't indicated as first line for the acute or delayed phases, but they could certainly be used, especially in refractory, sometimes in anticipatory, and in the case of antihistamines, you could use it for breakthrough nausea and vomiting. If anybody has any questions, though, we can certainly come back to these slides. So antihistamines, dopamine receptor antagonists, antipsychotics, cannabinoids, and benzodiazepines. I think that was it, yeah. So as I said, we can come back to those if anybody has any specific questions, but they're not really the focus of the presentation. And of course, there's lots of non-drug measures. So I think pharmacists also play an important role in remembering that drugs are not always the answer, or not the complete answer anyway. There's certainly things that we could be counseling our patients on that they could be doing at home, and things that would certainly decrease their risk of having nausea. So in the end, you've put your patient on this preventative therapy. What do you do? So you've been monitoring them throughout. Hopefully they did well through that cycle of chemotherapy. It was well tolerated and they were able to complete the full course. If that's the case, that's great. And in future cycles of that same chemotherapy, you would continue those medications unless there's been a change in chemotherapy, and then you start the process over. If that cycle, the patient required a lot of breakthrough, so as needed medications or PRN medications, or it was poorly tolerated, then the guidelines recommend that you escalate what you use for preventative therapy. So if they were being dosed or treated as a low immunogenicity chemotherapy regimen, you would escalate to the moderate. If they were on moderate, you would escalate to high. If they were already on high preventative therapy, the recommendation is to change the serotonin antagonist. So the default, because we have so much data and it's a relatively inexpensive medication, is ondansetron as a serotonin antagonist. So if that's what they were on, you can try granisetron. If they were on granisetron, you could certainly try palonosetron. It just depends on if they can afford that medication in that situation, at least in Canada. And then if that remains refractory, so they're still having a lot of nausea, then becomes more of a team approach. So you would start talking to psychiatry. We have a pain and symptom management team at CHIO. So they would come in and assess the child and make some recommendations. You can try some of the other medications that I sort of ran through quickly there, olanzapine or nabilone. Acupressure or acupuncture does have some data. So you're looking at other receptors that you can try to hit, even though they're not the serotonin or the substance P receptors, but yeah, you're just trying anything you can basically at that point. So just for a couple more minutes here, we'll go back to the patient case just to wrap up what happened with this child. So she was a moderate risk chemotherapy regimen. She could not take dexamethasone because she has leukemia. She was 6 years old, so she falls into the yes or no to aprepitant. She doesn't actually have any drug interactions with aprepitant. So she should have been on ondansetron and aprepitant, which isn't actually what happened. She was just put on ondansetron, regularly scheduled. And she didn't actually do very well for the first couple of days. She had a lot of nausea. She was quite tired. And she just, wasn't doing well clinically. So when myself and my preceptor got back to the ward on the Monday, we were able to add on the aprepitant, which would be as per guidelines. She should have been on that to begin with. And once she had the aprepitant, she actually did really well. She didn't have any complaints of nausea after that. She started eating again. So she got her 3 doses of aprepitant. The ondansetron continued for the rest of her chemotherapy regimen for the full 10 days. And in future cycles of that induction, she will get the aprepitant and the ondansetron right at the beginning. Mm-hmm. And then just to summarize the pharmacist's role, so I think we talked about this a little bit all the way through, but I think it's important that we review, obviously, the chemotherapy treatment that the patient is on, determine that immunogenicity, look at the guidelines, and make sure that we're putting the patients on the appropriate medications, they're dosed appropriately, that we've looked at the patient risk factors, as well as previously tried therapies or intolerances in the past. We monitor efficacy and recommend escalations as per guidelines, and that we counsel our patients and caregivers as you normally would with medications. And if there's a plan to discharge any of these medications, again, counseling and making sure there's drug coverage. And then finally, just to wrap up the whole presentation, so hopefully everybody is a bit more aware of how important chemo-induced nausea and vomiting is. And that if we manage it properly, we can certainly help the patient complete the treatment course and improve their quality of life, or at least maintain it. The mechanism of nausea and vomiting is quite complicated, but we have lots of medications that we can use. prevention is key, and that we have guidelines out there that really help us out and provide clear recommendations. We just need to follow them, and pharmacists certainly play an important role in all of that.
Super. Kendra, thank you very much. Yeah, excellent. Not any questions. We could just now change to Rosa. We are really sorry, Rosa, that we just ran slightly late, so we apologize.
Sorry. Yeah.
And that's okay. Don't worry. So Rosa, let's share your screen and let's carry on. Thank you very much, Kendra.
Sorry. Can everybody see that?
Yeah, it's moving. Something is happening. Okay. Yeah, perfect.
Okay. Can everybody hear me okay?
Absolutely.
Okay, great. So good evening, everybody. My name is Rosa, and I'm a pharmacy student at the University of Toronto, and I'm currently doing my fourth-year rotation at the Children's Hospital of Eastern Ontario. Today I'm going to be talking about a patient that I encountered during my rotation as well. And more specifically, I'm going to be talking about the interlink between chronic pain and mental health concerns. So these are the learning objectives that I believe that were sent to you before. So just to summarize a little, quickly, I'm going to be talking about complex regional pain syndrome. I'm going to be doing a case presentation for that. I'm going to be talking about the treatment and the pharmacist's role in CRPS. I'm going to be talking about mental health concerns and the case presentation for that. And I'm going to be talking about the treatment of mental health concerns and the pharmacist's role and serotonin syndrome. So first of all, what is complex regional pain syndrome? Complex regional pain syndrome, or CRPS, it's a condition of chronic peripheral pain, usually of an extremity. So that means it could be like that the foot is really painful, or the arm or the hand is really painful, or even the leg as well. It's a spontaneous or stimuli-induced pain. It's amplified to a very high visual analog scale score. So that means that it's very, very painful for the patient. The pain is disproportionate to the actual trauma or stimulus. And there are two types. There's CRPS type 1, which is more common in pediatrics. It usually happens after a minor fracture or trauma without significant, and in this case, there isn't significant nerve injury. In CRPS type 2, it's induced by partial injury of a nerve or one of its major branches. Type 2 is very rare in pediatrics, so this presentation is going to be focusing on type 1. CRPS can start in one limb, but it can go to the unaffected limb after, and unfortunately, the pain can spread to other unaffected parts of the body. In terms of the pathology and the signs and symptoms, so like I said before, CRPS type 1 usually happens after a minor fracture or trauma. The cause is unknown and the pathogenesis is unclear. However, they did find a couple of components here. There's a psychological component to CRPS. They typically find that in children, CRPS tends to happen after stressful life events. And it tends to happen as well if the child has been having some learning difficulties in school, or if they are worried about school, for example, if they are an overachiever, or they're worried about grades, for example. They've also found abnormal neurological findings. So there have been some small fiber changes that have happened with CRPS. They found an increased prevalence of inflammatory markers in patients who have CRPS. And there's been a genetic component as well. There's been there's a linkage between families. In terms of the symptoms that can happen, you can have constant pain in the affected limb, allodynia. So allodynia is when a small stimulus for pain, it causes a very, very, very large and unbearable pain for the patient. You can also have swelling and edema, temperature changes, hyperhidrosis, which is that the limb, it sweats a bit more. You can have changes in color. You can have motor disturbances as well. And you can have trophic changes such as hair and nail changes over time. So this is just a picture of what CRPS can look like. You can definitely see that, like in the left picture, the left leg is very inflamed, and it's turned a different color. And you can actually see that CRPS causes a fair bit of deformity in these patients, which is very unfortunate. So I'm going to go into our patient case now. So this is a 12-year-old female. I called her CW. She actually has quite a history with this pain. So in March 2018, she came to the emergency department with lower extremity pain. She had it for 3 weeks. They thought it was like plantar fasciitis. And in terms of what happened 3 weeks later with the resident, they found that she was having the foot pain as well. She was reluctantly bearing weight on the foot, and she was resisting any heel contact, so she wasn't able to put her heel on the floor. And there was no inciting history to this pain, so she was put in a walking cast for about 3 weeks. So a couple of weeks later, so the right foot pain has significantly improved. It got a lot better, so the cast was removed. 1 year later, in 2019, she had pain in her left foot and left heel. The pain's been there for about 2 months. And she was diagnosed with Sever's apophysis, which is very common in pediatrics. So she was put in another cast. About like in November 2019 of the same year, so she had pain in the right foot again along the apophysis and Achilles tendon, and she had limited range of movement, so she was put in another cast. A couple of weeks after that, she still had the pain, and it's been present for about 5 weeks. And it's at this point that the doctor thinks that she has early signs of complex regional pain syndrome, because she has a significant pain on contact along the entire lower extremity. So she was prescribed pregabalin, 25 milligrams PO/TID, along with other medications such as vitamin C, vitamin D, ibuprofen, and paracetamol. And she was also prescribed crutches and physiotherapy. A couple of months later, in January 2020, so they found that pregabalin was never filled, but she was still in pain, so they prescribed her naproxen 500 milligrams BID for 30 days. They discontinued her crutches, and the next month, in February 2020, they found that she's been having pain for 4 months. She's had no improvement with physiotherapy, but the pain is better with a boot. So she's still in significant pain. She walks with the front of her feet. She avoids heel contact. So we call this toe walking. She's had discoloration with the foot, and she's still tender. And she has allodynia as well. So a definitive complex regional pain syndrome diagnosis is made, and she's referred to the chronic pain service. And the medications don't change. So here we are at the chronic pain service right now in May 2020. At this point, the patient misses 2 days of school because of pain. She unfortunately has been in pain for 2 years. In terms of her mood, CW has been feeling down for the last couple of months. So her mood used to be a 7 out of 10, but last May, it was a 5 out of 10. She denies suicidal ideation. So suicidal ideation is when the patient expresses thoughts of suicide. The patient, she's been experiencing social anxiety at school. She worries her pain won't go away, and she's been having a bit of trouble sleeping at night. CW was unable to put her heel on the floor still. She is toe walking, and she still has the swelling. She's quite deconditioned because she's unable to straighten the knee, and she has some color changes to her foot. Her pain is unfortunately a 10 out of 10 on her best day and on her worst day. It's continuous, it's sharp, and it's aching. The patient, she stopped her pregabalin because it was ineffective, and she also had side effects. So I want you to pay attention here because these were the medications that were prescribed after intake, and I'm going to talk about them in a couple of slides. But she was basically prescribed naproxen, 500 milligrams every 12 hours with food. Baclofen every 8 hours is needed. Amitriptyline, which is a tricyclic antidepressant medication. And over-the-counter lidocaine cream. In terms of other parts of the care plan, she was referred to physiotherapy, and she attends it once a week. She was recommended to discontinue the air cast, and she was referred to a session with the occupational therapist to set some goals, and her follow-up was in 4 months. In terms of the treatment of pediatric CRPS, there are a couple of goals. First of all, we want to offer pain relief to the patient. We want to offer improvement in all domains of the patient's functioning and in their quality of life. There are three mainstays for care. There's physiotherapy, there's pharmacological therapy, and there's psychological therapy. Physiotherapy is very helpful for patients, but there's no consensus regarding the duration and the intensity and the content for physiotherapy. The usefulness of psychological treatments has been demonstrated in many patients with pediatric CRPS and with chronic pain. In terms of the pharmacological treatment, you see a plethora of medications there. So they've used anti-inflammatories such as NSAIDs, paracetamol, amitriptyline, gabapentin, and pregabalin, which target the neuropathic pain component. Muscle relaxants, which targets the myofascial pain. The lidocaine ketamine topical, and we've also used infusion therapy like with lidocaine or bisphosphonates. We've also used SNRIs like duloxetine and venlafaxine, which are other types of antidepressants, and ketamine. In terms of the role of the pharmacist in this case, so the pharmacist always evaluates the patient's medications for indication, efficacy, safety, drug interactions, adherence to treatment, and the cost and convenience of treatment. And the cost and convenience component is actually important in this case because the patient is, this is an outpatient for CRPS. The pharmacist also ensures that allergies and intolerances are up to date. For this patient, the pharmacist found that the patient's pain was both myofascial and neuropathic and inflammatory in nature, so they recommended a combination of naproxen and baclofen for the inflammatory and myofascial pain, and also amitriptyline at night for two reasons. The amitriptyline would take care of the neuropathic pain, but it also has the side effect of fatigue and sleepiness, so that would help her sleep. They also prescribe lidocaine cream. I'm just going to stop and explain this for a second. At JÍZYKU, we typically what's recommended for CRPS patients is the combination of a lidocaine ketamine cream. However, this mixture can be quite expensive, and money was an issue for this family. So the pharmacist recommended like 5% over-the-counter lidocaine cream, which would have been effective for the pain as well. The pharmacist recommends doses for medications based on the patient's weight, as is commonly done with pediatrics. And the pharmacist also provided education with regards to the adverse effects of medications. In this case, the pharmacist made a list of medications that were tried before and that had that the patient had a intolerance or bad reaction to, such that these medications weren't tried in the future. And the pharmacist also made a list of medications that were never tried, such that these could be potential options in the future in case of therapeutic failure. I'm going to switch gears a bit and talk a little bit about social anxiety and depression in children, so mental health concerns, because mental health concerns like anxiety and depression are actually very common in patients who have chronic pain. So for social anxiety, which is what this patient has, she said thoughts can include, I'm going to say something stupid, or they won't like me. They can include physical sensations such as stomachache and sweating, blushing, muscle tension, and irritability. They can include emotions such as anxiety, worry, fear, embarrassment, and some behaviors such as school refusal and participating in new activities or declining invitations to social events. In terms of the depression symptoms and signs, the child can be irritable, sad, or bored most of the time. The child who's depressed, they may lose or gain weight. They may sleep a little bit or too much. They feel hopeless, worthless, or guilty. They think about suicide or death a lot. They can also avoid school and self-harm. They also don't take pleasure in things that they used to enjoy. Let's switch gears back to CW. In November 2020, CW came back to the clinic, the chronic pain clinic, and her heel pain is getting better. Her sleep has improved, which is good. The patient was prescribed baclofen 5 milligrams prior to physiotherapy in August 2020. Then the naproxen twice a day was stopped because the doctor wanted to reduce the risk of ulcers in the patient. And the patient is currently taking amitriptyline 20 milligrams at night. In terms of her mood is still low. It's a 6 out of 10, and they found that her low mood can actually worsen pain. The patient worries about pain in school, and she has a follow-up with the psychologist on December the 1st, 2020, and she's been going to CBT or cognitive behavioral therapy sessions as well. These are the medications that were prescribed. The only changes of note is that, like, she was prescribed ibuprofen every 6 hours for pain, and acetaminophen or paracetamol every 4 times a day for pain as well. And both of the medications were 3 times a week maximum. Okay, let's talk about CW and her mental health. She was reporting suicidal ideation in December 2020 with the chronic pain service psychologist. And the chronic pain service psychologist discussed a safety plan with the patient's parents, such that they had to get rid of ropes, certain medications, and sharps in order to keep CW safe. The psychologist also discussed the safety plan with the CW as to when to call emergency services. CW, over the course of from December to February 2021, felt that her parents didn't understand how she felt. She reported that she has what's called an inner bully or inner critic, and she wasn't able to take a compliment. So you see a lot of those symptoms and signs of anxiety and depression here. And CW also felt a lot of anxiety with regards to school. For example, she feared upon being called upon in class by her teacher. She was experiencing panic attacks with tests, such as she felt heavy, and she had sweaty palms, and her heart rate was increased as well. And she also had, she was also distressed when she interacted with peers. She declined invitations as well for social events when she didn't know people in the past, and she often would ruminate over the content of conversations even months later. On February the 22nd, 2021, she was experiencing worsening suicidal ideation because she was waking up in the middle of the night and she wanted to overdose on ibuprofen. And this got worse, and on February 28th, she was admitted to the hospital for suicidal ideation because she wasn't able to keep herself safe at home. Over the course of the hospital admission, she was in the hospital for 9 days. The amitriptyline dose, so this is the antidepressant dose, it was increased to 30 milligrams at bedtime. And she was prescribed melatonin, 3 milligrams sublingual as well to help with sleep. Both of those medications were started or changed because she was having some sleep difficulties. She was started on sertraline, which is a serotonin antidepressant, and it was 25 milligrams once a day. Eventually, at the end of her admission, she was titrated up to 75 milligrams once a day by discharge. CW had some psychotherapy sessions with the chronic pain psychologist that she had been seeing for a couple of months, and she had some sessions with the occupational therapist, and she focused, in which the sessions focused on emotional regulation and recognition. It was recommended for CW's parents to work with social work such that they could further support their child as well. Let's talk about the pharmacist's role in mental health hospitalizations, and let's talk about some of the therapies that are used in children as well. The role of a mental health hospitalization is to stabilize patients after a mental health crisis. Realistically, the role of the mental health hospitalization at CHIL is to stabilize patients from a mental health point of view when they are a danger to themselves or a danger to others. And so the point here is to start and or optimize their mental health regimen such that once they are able to get out of the hospital, they are at a they are pretty well optimized for their mental health regimen, and hopefully they're able to be followed up in the community by the community pharmacist and by their family doctor as well. So in this case, CW is a chronic pain patient, so she comes to the chronic pain clinic every couple of months. So she has some pretty good follow-up here, so there aren't any concerns with that. The pharmacist, throughout the course of the hospitalization, ensures that the medication starts and changes are appropriate and safe for the patient. Because the hospitalization is so short, the medications tend to be titrated up fairly quickly. In the community, let's put this into context. In the community, when you start an antidepressant, the medication dosages are titrated up every 2 to 4 weeks, for example. In the hospital, the medication doses for antidepressants are titrated up over the course of over every 3 to 4 days to make sure that the patient is at an optimal and there is an optimal dose by the time they leave. So for pediatrics, the first line of medications for the treatment of anxiety and depression in children are selective serotonin reuptake inhibitors, or SSRIs. Fluoxetine, it's a medication that has evidence in both anxiety and depression, but it can be quite activating, so it can keep you awake a little bit more than other antidepressants in this class. So that wasn't really an option for this patient because she was having trouble sleeping. Paroxetine, it's another option, but it's not really used very often because it can be very sedating. But it does have evidence in anxiety and depression. Fluvoxamine, it has evidence in anxiety, but it does cause nausea and vomiting, so that wasn't, or more than other agents, so that wasn't, that probably wouldn't have been a good option for this patient. So the doctor went with sertraline. So the pharmacist was making sure that the patient didn't have any side effects as the medication was titrated up very quickly. And also she made sure that the patient was at a good dose. So the patient was at 75 milligrams of sertraline by the time she left the hospital, which was a good dose. The pharmacist also protects against serotonin syndrome. And I'm going to get into that very quickly in a couple of slide, because serotonin syndrome is a concern when you start an antidepressant or when you combine 2 antidepressants, or even when you increase the dose of an antidepressant. I'm just going to stop here. Does anybody have any questions before I continue? Okay. So
No questions. Yeah.
No questions?
No.
Okay. So just quickly, serotonin syndrome is a rare, but it's a very serious drug reaction because there's too much of this chemical serotonin in the brain. Serotonin syndrome is mostly a concern when you have antidepressants called an MAOI on board. And they are the highest risk serotonin medications. They are most commonly implicated in this condition. Also, medications of concerns are cough and cold medicines that have dextromethorphan, or DM. Some of the serotonin-releasing street drugs, such as MDMA, amphetamine, and cocaine. Some opioids, such as methadone, fentanyl, tramadol, and demerol. And some natural medications as well, such as St. John's wort, diet pills, and tryptophan. And Parkinson's disease medications, such as selegiline and rasagiline. These are the signs and symptoms of serotonin syndrome. So you can see it can range from mild to moderate to severe. In mild cases, you can have nausea, diarrhea, tremor, large pupil. Moderate cases, you can have hyperreflexia, sweating, agitation, and side-to-side eye movements and clonus. Severe is when you have like a fever, confusion or delirium, rhabdomyolysis, and death. So I'm going to get into this in a bit, but as soon as you recognize one of these symptoms in a patient, and I'm going to get into the specific criteria in the next slide, and the patient is on an antidepressant, you should really be asking the question, okay, should this person be referred to the hospital? And just as an aside, the selective serotonin reuptake inhibitors, such as fluvoxamine, sertraline, for example, if you overdose on those medications, 15% of the time they found in studies you'll get moderate symptoms. Serotonin syndrome really is a concern, as I said before, with the MAOI medications. I put these the Hunter's decision rules here because these are truly it's an algorithm to decide should this patient be referred to the hospital or not for serotonin toxicity. Serotonin syndrome is always a medical emergency because of the implications. The patient could pass away. So you can see here that as soon as the patient has spontaneous clonus or inducible clonus or any type of clonus, excuse me, or if they have hypertonia or a fever, that's indicative of serotonin toxicity and they should be referred to the hospital. In terms of the treatment in the hospital, so first of all, you need to recognize the toxicity and you need to discontinue the medications that could be causing this toxicity. There's no real treatment guidelines on how to treat this syndrome. The treatment is basically guided on the severity of the presentation and the symptoms that they present with. Hyperthermia should be managed with external cooling, benzodiazepines, and hydration. There's not really a role for central thermoregulators such as paracetamol, which decreases the symptoms of fever, because the pathology of hyperthermia in this case and fever is different from the centrally mediated mechanism that you would see with an upper respiratory tract infection, for example, or any type of infection. Patients with a fever higher than 41 degrees, they need to be intubated and they need to be have neuromuscular paralysis. And in terms of like treating agitation and delirium, people, they typically use non-pharmacologic strategies in the hospital and benzodiazepines when appropriate. Other agents include dantrolene, which is used in neuroleptic malignant syndrome. And they also use as antipsychotics that have serotonin antagonism, such as chlorpromethazine. But we don't typically use that very often because it can have some severe side effects, such as severe hypotension. Most of the time, and especially for moderate serotonin syndrome, we use cyproheptadine, which is a serotonin antagonist. All right, so I just wanted to go through a couple of questions here just to see, just to test some knowledge here. So, which of the following are mainstays of therapy for CRPS? I'm open to any participation here.
I think we have to help them. We have to help them.
Okay.
Yeah.
Okay, so I spoke about three ways that we can treat CRPS, right? So technically, like, it would be all of the above. So we use psychological treatment, pharmacological treatment, and physiotherapy in CRPS patients, and and all of these treatments pretty much treat the pain very well.
Mm-hmm.
Which of the following is a first-line medication for the treatment of anxiety in children? Okay, so it's typically A and B. A and B, like fluvoxamine and sertraline, they are selective serotonin reuptake inhibitors, and they're typically used as first line. Venlafaxine isn't really used as first line because it typically carries more side effects. But if there was a family member who responded well to venlafaxine in the past, then we would probably go with venlafaxine. Last question. Which of the following is a symptom of severe serotonin syndrome? Okay, it is fever. So whenever somebody has a fever and they have the other symptoms of serotonin syndrome, things can go south very fast. So this especially is a medical emergency. I'd like to thank the following people who helped me throughout my rotation, and I learned a lot with everybody. And here are my references. Does anybody have any questions?
For me, it was an excellent session. I really enjoyed it a lot. So thank you very much. I think some of the news were really good. So thank you very much, Rose. It was
no problem.
Yeah, and references. Yeah.
We're on references. Okay.
Yeah. I mean, both of the topics, they were quite difficult, but anyway, my main focus about the session was to show to the Polish pharmacists that this is how much they need to improve, and this must be a motivation session tonight actually, and I think we are at the beginning of the way, but this was a great piece of work. Thank you, my dear guests, Kendra and Rosa.
Thanks for having us.
Thank
It's
you for
always
having
a
us.
pleasure. So obviously, I would like to thank you to Dr. Regis Vaillancourt, the head of the pharmacy in CHIO, for allowing me to perform these sessions a few times with all the magnificent guests. So thank you very much. And we are hoping that soon you will just finish off with your PharmD, because I think this is your last moments. Yeah, am I right?
Second last rotation.
It's getting there. Yeah.
Excellent. So it's just nearly done. So this was great. Thank you very much. We are slightly over the time, but doesn't matter. I think it was a very good piece of knowledge. So I would like to thank you to everybody for being with us tonight. And thank you, ladies, for first of all, preparing such a very thorough presentations. Thank you for involving so much in basically presenting the knowledge and all the efforts. So thank you very much. For me, it was excellent.
Thank you.
Thank you.
So enjoy the rest of your day. And for us, we are going to bed.
Okay. Good night.
Excellent. So thank you very much and see you soon.
See you soon.